And unlike many of Novo's other actions targeting compounders, this one is a straight patent lawsuit with clear legal claims, and it could have real implications for the people who rely on cheaper compounded GLP-1 products. Now, before we get started, I'd like to let viewers in on a little secret. At the end of every episode, we do a quick off the record segment where you can ask me or the team questions, share your progress, or just hang out. Trace, can we put a registration link on the screen, please? This is a chance to better connect with our community, peek behind the scenes, and have a little fun together after the show recording has stopped. It's not exactly inside baseball, but we do the best we can. But right now, Dave Knapp, welcome to Lifelong.
Ethan, thanks for having me, man. It's great to be back.
Now, I got to ask you because I don't know what's what, but is
Yeah.
is this lawsuit done? Is the lawsuit still happening? Have they settled? I mean, this stuff moves so fast, but they are Novo is suing Hims, right?
They are. And the way that you teed this up, I'm like, man, why is he having me on this show? He's got it down pat. You're gonna take my job.
No, here's my question to you. I guess there was some part of me that had this idea like you can't patent a
Yeah.
peptide, but
Yeah.
maybe you can now.
Yeah.
I thought they were putting something. I thought Novo had some formulation that maybe the compounders weren't selling. So I don't
Yeah.
know. I need to know. I need the
Yeah.
inside dish.
Yeah, well, let's get into it. So you're exactly right. Novo dropped a lot. Well, I always use the word dropped, and people are like dropped. They got rid of it. What I mean by that is they filed a lawsuit against Hims, as you laid out. The interesting thing is Novo Nordisk has filed well over 100 lawsuits against different compounders. So anywhere from a med spa to the actual compound pharmacies that make the medication, right? And the interesting thing is, Ethan, until today, not a single one of those lawsuits actually went after patent infringement. They went after copyright infringement. And I realize this is getting a little nerdy for a lot of folks, but essentially they were just saying, hey, you can't use the name Ozempic when you market your compounded versions. You can't use the name Wegovy. And so that's what the over 100 different lawsuits focused on. This is the first lawsuit from a pharmaceutical company against a compounder that goes directly after patent infringement, the actual molecule. And you're right. When I got into this, I didn't think it was possible to actually hold a patent on a peptide, especially a peptide that for all intents and purposes mimics a naturally occurring hormone in your body. But in fact, you can. And the more I got into it, the more I really started to understand that peptides, especially these GLP-1 peptides, they're doing more than mimicking a hormone. And in fact, they're binding better to the receptors in some cases, and they're designed to last in your body for like a week compared to your endogenous hormones that last just a couple of minutes in your body before they're destroyed. And so for a whole host of reasons, there's actually quite a lot of innovation that goes around these molecules, and Novo Nordisk being the patent holder on semaglutide, the active ingredient, at least for a few more years here in the United States, is trying to defend their territory, mainly in response to the fact that they had an unprecedented launch of a pill version of their shot Wegovy that actually showed in clinical trials that at the upper dose, the pill was as effective as the weekly shot.
Wow.
And then Hims came out and said, hey, we've got a cheaper version of this for $50. But as you said, it was not an apples to apples.
Right. But okay, so it sounds then like they've got a case and they should probably win this, no?
Maybe. So
Maybe.
so I think there's a reason why all the 100 different cases that preceded this did not directly go to the patent. And I think that the pharmaceutical companies in general were trying to avoid this type of lawsuit. In fact, I kind of think, and this is my own personal thesis on this, is that Hims actually wanted this fight.
Oh,
And
wow.
the reason I believe that is because I think Hims and I use Hims, but really I mean more broadly the compounding industry sort of holds that ideal that you do, that peptides ought not be patented by pharmaceutical companies, and they wanted to have this day in court. So I think I could be 100% wrong about that, but it seems like the actions of Hims were rather egregious. In fact, in the fall of 2025, the FDA sent a letter out to to hims and hers. It's public information. We covered it on the pen. And in this letter, they basically said you have to stop saying that your compounds have the same active ingredient as Ozempic and Wegovy. And they just very plainly did not. They were very defiant in that and did not. And up until the launch of their pill last week, where there was meta ads and programmatic ads running online that all said same active ingredient as Ozempic and Wegovy. So they continue to defy the FDA and essentially what Novo had been citing in these lawsuits against other compounders. So it seems like they wanted this fight. And the only thing that makes logical sense is kind of how you laid it out at the beginning. They don't believe that these patents are valid.
So there is a universe where they could have just said, we have a pill version of semaglutide, and this lawsuit wouldn't maybe have happened.
In terms of them not using the brand names, you mean?
Well, it almost sounds like they were antagonizing Novo. They were poking them bear with the stick a little bit. If they had just said, like, we have a pill version of the most radical weight loss drug ever to be known to man, but didn't mention Wegovy or Ozempic, maybe they just get copyright infringement it's
possibly.
Yeah.
I think possibly, but I think the other thing that you have to take into consideration, and again, I apologize. I follow this stuff so closely.
I thank God you do.
but the way that I kind of see it is, Novo Nordisk, they launched Ozempic, 3 or 4 years ago, maybe a little bit longer, and they really lost the battle early on controlling the proliferation of compounds, lost or depending on how you look at it, but they lost control of it for sure from an investor standpoint, and they've paid dearly. Their stock price has paid dearly because they've openly said on their earnings calls that they've lost a pile of money due to compounding. Now, conversely, Lilly, who makes Mounjaro, which is the injectable version of tirzepatide, Zepbound, another GLP-1 category drug for obesity and diabetes, they've said very publicly that compound hasn't hurt them, but there's, by all estimates, maybe 4-to-1 folks are using compounded semaglutide versus tirzepatide. So it hasn't hurt Lilly as much, but having lost that battle very early on, Novo and they've failed pretty much every step of the way at these lawsuits, these kind of more, mom and pop, shutting down med spas and stuff. They haven't been super successful in those lawsuits either. And I think that they sort of, because of how egregious this was, they launched this pill. They were getting a ton of press. They had this major earnings call last Wednesday. And then Thursday, boom, Hims comes out with their pill. I think it was, as you said, defiant. I think it was more about the timing and that they were putting Novo Nordisk in a position where they had no other choice but to defend their intellectual property, because otherwise their investors would likely revolt.
Yeah, I mean, the whole thing is a strange problem of marketing, I think, because from my conversations with you, my conversations with Dr. Mike Israetel, who I've talked to a lot about these things, Zepbound and Mounjaro are a better drug, right?
Yeah.
And yet they suffer from the fact that the first drug to come and become popular was Ozempic.
Right.
Which many people still call all GLP-1s Ozempic, right?
Correct.
And so because of that, people reach for that even with the compounding and don't reach for the other with like the whole thing seems like a marketing problem. I would have thought Novo's winning just because they have the more popular name.
Yeah.
And yet it's hurting them more too at the same time.
Yeah, I think being first to market is a double-edged sword when you're coming first to market with a game-changing class of medications, right? And it wasn't the first one, but the first like highly effective.
The first one that just caught fire that you heard about. Hollywood is taking Ozempic and all of this.
Yeah, and sort of like became part of the cultural zeitgeist, right? I mean, Ozempic, as you said, it's sort of like interchangeable for all these weight loss shots is just the word Ozempic. It became, so yeah, I think that's really where they paid the price dearly, is just being that first to market and really, the double-edged sword of becoming a household name. That's kind of what everybody demands. And then they really took a hit from the compounding. So when they had this launch of this pill, which by literally blew all of the estimates out of the water, it blew their own estimates out of the water. It blew the investor community's estimates out of the water. I think it was some 170,000 scripts the first 3 weeks, which blew Zepbound out of the water. It blew the injectable Wegovy out of the water, and partially because, as you said, like this has proliferated through society a lot more than it did when those drugs launched, but also because there's an approachability to a pill that you don't get with the injectable for a number of reasons. Like perhaps people find it a little bit less clinical. I think people really struggle, and I don't know if you can relate to this or folks in your community can relate to this, but nobody really likes the title obese or obesity. Right. It seems highly clinical, right? You'd rather just be like, I just need to eat less and move a little bit more. But for those who really struggle, and for those with the diagnosis, I think a pill is a little bit more approachable, simply because many people are already taking a pill for one thing or the other, and it doesn't feel quite so clinical.
Yeah. Or, at the very least, you throw it in with your vitamin regimen if you're not even into pharmaceuticals. And yeah, no, I completely agree. I think pills are way more just even socially acceptable than injections.
Yeah.
Injection, right. Has that implication. Like my daughter has type 1 diabetes, and I'm a sober person, and I remember having to give her first shot. It was like it felt weird. I didn't feel good about doing it, but it saved her life.
Yeah, absolutely. And I think you can't discount, again, the stigma that goes with living with obesity, whether we're putting that on ourselves or the people around us are putting it on us, or society, however you want to couch it. At the end of the day, I think that when you think about the plausible deniability of, because again, Ozempic is in the zeitgeist. So it's like, are you on that weight loss shot? There's sort of a plausible deniability and be like, no, not on the shot.
No, I'm getting it in pill form now.
I'm on the pill. Right.
Okay, well, here's another question, because I read earlier in the week that the FDA was cracking down on all compounding. So why is that not cracking down on Hims?
Sure. So there's so much going on all at once. So Novo has their earnings call last Wednesday. They talk about how the pill is just blowing it up, right? They also adjusted their earnings down because they are losing their patent in other countries. So they're facing sort of these headwinds of expiring patents around the world, not in the US, but in markets like Canada and India. And so, they actually adjusted their market forecast down, but the bright spot was the pill. The next day, Hims comes out and says, we got the same thing. And I'm happy to get into why it's very much not. But we got the same thing for $50 a month, $150 cheaper, right? So really it was, as we said earlier, kind of egregious. So the interesting thing about Thursday was also the launch of a little website that people may have heard of called Trump RX. And Trump RX is the culmination of the most favored nations negotiations, one of Donald Trump's administration's crown achievements in healthcare, where he brought in the CEOs very publicly from the pharmaceutical companies and said, hey, if you want access to Medicare, at least on the GLP-1 side, you're going to have to play ball and lower the cost. And really the two crown jewels of Trump RX are that he got Lilly and Novo to agree to release these pill versions of GLP-1s that are coming out this year at a much lower cost than the injectables. And you might say, well, that just stands to reason because those injector pens are so much more expensive. Yeah, but when you think about it, there's an oral GLP-1 already on the market called Rybelsus. It's the same thing as this oral Wegovy, but for diabetes in lower doses, and it's still $800 or $900 a month for that prescription. Yeah. So really, it was just one of their crowning achievements for the Trump administration to say, hey, they're launching these pills, they're as effective as the shots, and they're going to be $150 to start, right? And so the same day that they launched Trump RX very publicly, Hims came out and said, we got it for $50. So it kind of undercut the administration.
Wow.
And so there's a lot of people who thought that the immediate response, and it was literally immediate. There were tweets. And then the next day on Friday, there was a scathing letter from the FDA that essentially said, we're going to crack down on the active pharmaceutical ingredients of unapproved copies of branded medications. And they mentioned Hims by name in the release. And then they also said, for those who are marketing these inappropriately, which I really think is ultimately, in hindsight, why they released this is because of the marketing, the egregious, it's the same active ingredient. The reason I think that they put that statement out is to put a little bit more teeth behind what they've already said publicly to Hims. Interestingly enough, the day before, and we just found this out today through a report from Bloomberg, but the day before, the FDA sent out a very similar letter to Novo Nordisk saying, hey, your advertisements about Wegovy are misleading. They're leading people to believe that the pills are better than the injectables. And while they're about on par with the injectable Wegovy, they're definitely not on par with tirzepatide, right? So they took umbrage with the marketing of the Wegovy pill by Novo Nordisk too. And so I think it, instead of it being a really heavy-handed response, I think it was more of a even-handed response from the FDA because they hit both of them. And so there's a lot of question right now as to whether this will extrapolate out to all compounded versions or whether this is just a response to the pill. Some of it remains to be seen, but I think that the FDA almost had to respond because when we're talking about the pill and the compounded versions of the pill, there are some very specific reasons why the compounded pills are a whole different ballgame compared to the injections. I'm happy to get into that if you want.
Yeah, well, tell me why is it a whole different ballgame?
Yeah, so peptides are very unstable when they're consumed orally. In fact, most shorter chain peptides will just be immediately dissolved by stomach acid, and they won't be able to be absorbed by the body at all. And semaglutide is no different. In fact, when Novo Nordisk wanted to convert semaglutide into a pill, they acquired a company for a specific technology called SNAC, SNAC. They acquired this intellectual property for about $2 billion. And this $2 billion technology makes semaglutide about 1% bioavailable. So ultimately what this means is to get the same amount of efficacy that you get in a 2.4 milligram once weekly shot. So once a week, you're taking 2.4 milligrams of semaglutide. That's all the ingredients, active ingredients that are in it. To get the same thing out of the pill, you are taking 25 milligrams once a day. So literally over 70 times the active pharmaceutical ingredient per week. And that's using a $2 billion technology. So when a compound pharmacy stands up a compounded version, it stands to reason that they're not using a $2 billion technology to make sure that you're actually having some of that peptide absorbed by your stomach. And really what the technology does is it just wraps the peptide up in a fatty acid that allows the stomach acid to deflect the stomach acid and allows 1%, around 1% to be absorbed. And really it's like the gremlin of pills because you have to take it first thing in the morning on an empty stomach. You can't eat for 30 minutes. So there's some rules with it, even with that $2 billion technology around it. So I think the FDA had to say something.
Yeah, I mean, and then it just makes me think whatever's him is selling can't be all that great, or they would have already been selling it.
Yeah, I mean, of course, from their perspective, they're leveraging some liposomal technology or something that's supposed to make it bioavailable. But I think the point on the FDA, I think where the FDA had to step in was that type of technology has never been tested on a large scale. They don't know whether perhaps more of the medication is absorbed. We'll never know. And so what are the implications for patients? So I think this became a unique patient safety issue that at least by the FDA's, if you can infer by the FDA's lack of inference in this or interference in this at all prior to, and they've said little things here and there about, the compounded versions not being FDA approved or this or that. But the teeth behind this, I think, is more indicative of the fact that the pill is just not a one-for-one swap in the way that maybe one would argue the shots are.
Yeah, there's really no part of me that wants to feel sorry for the big pharmaceutical companies. It's just not something I ever think like, oh, they're really getting it stuck to them. However, I will say like we wouldn't know about any of this if it wasn't for them doing years and years of research and spending
Mhm.
an awful lot of money to bring this stuff to market in the channels that are set up in America to bring. So to
Mhm.
put all that effort, time, and money into it, and then to have somebody just go, well, I can whip that up in my kitchen
Mhm.
and sell you basically the same thing. It does feel like a conflict to me.
Yeah, I think this is sort of, I did a live over on YouTube. I'm live Monday, Wednesdays, Fridays, and I'm like, this is a different topic every day. This was obviously the topic that ruled the day today. And, kind of what I was saying, Ethan, because I'm feel the same way. Like, I don't want to come off as some like pharma shill, but at
Right.
the same time, what I feel like on the pin exists, well, not what I feel like, what on the pin does exist for is to bring patients information that empowers them to have better conversations with their doctor. And so everything that we share information wise is cloaked in patient information. And so it's not subservient to pharma and it's not subservient to compound industry, it's subservient to patients. And I think when you're looking at this objectively, I think you have to acknowledge what you said. The pharmaceutical companies, from their perspective, they spent billions and billions of dollars on research and clinical trials to prove the safety and efficacy of the molecule, even if they didn't invent it, which semaglutide was actually a product of NIH research that ultimately Novo Nordisk bought the rights to. But see, Novo Nordisk took a huge gamble to bring semaglutide to the market because, especially for obesity, because this was, and still to this day, is not something that payers, the insurance companies, view as a disease. It's a cosmetic issue in their view. So they were going to put billions of dollars into a drug that they weren't confident was ever going to be covered by an insurance company. But so I don't want to be a pharma cheerleader, but also I respect the fact that they put billions and billions, tens of billions of dollars into these to develop them, bring them to market, and change people's lives.
Right.
On the compound side, they've challenged these patents in patent courts and essentially said, anybody could make these. They're just a copy. And it's like, well, if it were that simple, then just do it. Make your own peptide that works as well as semaglutide, that has a 7-day half-life, that helps patients lose 15% of their body weight in a year. Do it. But the reality is it's just simply not that easy. And so it's complicated because patient access is a huge thing. Compounds have been a huge pressure release valve for patient access to these medications. And furthermore, when we talk about the fact that these drugs are now being offered cash pay, circumventing our entire insurance system to be a pressure release valve to a very broken system, that wouldn't happen without the competition that these pharmaceutical companies all of a sudden had to face from compounders. I firmly believe that they were a catalyst for this cash pay market. So, there's arguments that can be made on both sides, but I think, what I was saying in my live, it's kind of like sometimes the bully, is a little bit easier to deal with because it's predictable. I was sharing kind of a story, if I can just kind of opine for a moment. When I was a kid, there was these two dudes on the playground and they were both tough dudes. And I was a real peacemaker. So I was kind of like the guy, like, can't we all be friends? But there was this kid named Adam, this scrappy little mouthy little guy. Right. But the kid who ruled the playground was this dude named Luke. And Luke was in third grade, but he looked like he was about 32. Like, I'm pretty sure he had facial hair, maybe tattoos. I'm not sure, but that's how I remember him in my mind. And Luke ruled the playground, and he didn't really rule by being violent. He ruled by just being big and assertive. And you didn't want to cross him because he was big and he knew it. And one day, Adam, decided, I don't know whether he just wanted to flex or not, but he got into it with Luke and decked him in the mouth. And Luke's bleeding everywhere. And from that point on, Adam was kind of the guy who ruled the playground, except Adam would be violent with people. And so sometimes the bully that is, easier to deal with or maybe more predictable. And kind of like I said earlier, too, we've built a lot of political and regulatory infrastructure around the bully that we know being pharma. And maybe bully is not the right word, but I think everybody understands kind of what I'm getting at. We built a lot of protections to make sure that the drugs that they produce are safe, that there's accountability when there's not. And I realize that this probably gets a lot of people hot under the collar because not everybody's going to agree. But with the pharmaceutical compounding industry, we've never had compounds on this scale where you
Right.
have literally millions of people on a non-FDA approved injectable drug. And we haven't built the regulatory framework around that. And so I think it's probably an appropriate time to talk about what does some appropriate regulatory framework look like? How do we allow access to compounds and custom doses and custom formulations, which is kind of the heartbeat behind why we have compound pharmacies to begin with? How do we do that and also protect the sanctity of patents so that we can continue to drive innovations for the people who semaglutide and tirzepatide aren't the answer for their metabolic woes? Because we want the next generation of drugs. We want the retatrutides, the triple agonists. We want the quadruple agonists that we don't even know about yet. We want all those things. And so how do we balance accessibility and incentive? And so these are just conversations that we're going to start to have, whether we like it or not.
Yeah, I think so. And that's so beautifully put. I want to pivot to a question about not about policy, but did you watch the Super Bowl?
I did. I
Okay,
did. Yeah.
so my entire Super Bowl experience can be summed up as this. I went from wanting to eat Dunkin' Donuts and really enjoying that commercial a lot to feeling ashamed by Mike Tyson,
Yeah.
who I thought was calling me pudgy, but today I learned maybe he was calling me fudgy. I don't know. And then immediately after that, I went to seeing one of the greatest female athletes in America
Mm.
on, I think, tirzepatide.
Yeah.
And I was just like, well, shit, man. If Serena
Mm.
Williams is taking this and she's truly one of the greatest athletes in America,
Right.
doesn't that just say that everybody should be taking it?
I mean, in a way, right? I think first of all, I kind of echo the roller coaster that you were on. It was very, very food and weight centric in terms
Yeah,
of the ad spend this year, right? Which makes sense. I mean, this industry is printing money because the problem of obesity is so, no pun intended, large. I mean, listen, this is a statistic that blew my mind because they say that, like 40% of Americans are obese, but really obesity is measured by this broken metric called the BMI. But if you took like the waist to hip circumference ratio, and some of these other things that they're looking at, it's actually estimated that about 70% of Americans are living with some sort of overweight or obesity that could potentially benefit from these drugs. 70%. There's what, 400 million people in the United States. That's
right.
a good number of people, right? To your point about it seems like everybody should be on this. I think what the Oprah story and the Serena Williams story show both is that you have two examples of two women who have achieved absolutely everything in life. And the broken narrative of obesity is that these people are lazy, that they don't have the willpower, that they lack the fortitude that it takes to just eat less and move more. Nobody had accessibility to better food, better training than an athlete at the top of her game like Serena Williams. Nobody has more money than a person like Oprah and have every tool at their disposal. Yet this part of their health journey was elusive. It was elusive because what we've learned about the disease of obesity and pre-obesity is that there's hormonal dysregulation. And I would love someday to just do a deep dive with people that are a lot smarter than me about what those things are, because I think we could point our fingers at a lot of things that screw with our gut microbiome, which is where these hormones all originate. But the point is there's dysregulation in the gut, which is where all these nutrient stimulated hormones that these drugs are mimicking come from. So whether it's the antibiotics that we've been overprescribing, whether it's the GMOs or the pesticides or the alcohol, hard alcohol, whatever it is that's destroying that gut microbiome, genetics, whatever it is, there's dysregulation. And I think someone like Serena coming out and saying, listen, I did everything. I was getting all the training. I was working out, 7-8 hours a day. I was dialing in my exercise. It shows people that, hey, you're not alone. If you feel like you've tried absolutely everything, obesity is a chronic relapsing disease, even if you get it controlled for a while, you're not fixing the underlying issue with the signaling. And eventually it's going to come back. You could talk about set points, all these things, all these nuances of obesity that relate directly back to broken biology. And so it opens up the conversation for people like me, because it's like just sort of all of a sudden the collective conscious opens up and they're like, what? Serena Williams, why would she need this?
Right.
So let's sit down and have a conversation about that. And that's where I really get excited about the future of people really opening their minds to, understanding that there's something wrong with our biology. And I agree with you. I think at some point people will be on some form of these, most people, not because most people need to be medicated, but because most people struggle with overweight. And these seem to be the antidote to whatever it is that is plaguing us from a metabolic health standpoint.
Well, this does lead me to a policy question that I want to pose to you then. Given those stats, 70% of Americans, 200 plus million people are at least overweight. And we know the health risks associated with that. We're not going to beat around the bush. We know the cost, the cost on infrastructure of healthcare that
Right.
presses. Why on earth are they not subsidizing this? Why are they not? Why are insurance companies who are going to have to pay for the diabetes and metabolic syndrome and the cancer risks that are associated with being overweight and everything else that comes with it, that's going to cost them a hell of a lot more than just getting one of these drugs to somebody early?
Yeah, I think it's the question. It is the question. And I think the simple answer is that insurance companies are looking at you as essentially a 3-year math problem. They only have to deal with you for about 3 years. And so you're going to cost them what you're going to cost them for 3 years. And they obviously trying to keep that down as low as humanly possible. And whatever 3 years use of GLP-1s does for you, they're paying the tab, and then somebody else is going to benefit from it. Now, you could argue, like, if they just all did it, then the whole industry would benefit from it, right? But like, who's going to be the first? And I think as the evidence continues to mount, I think things are going to become more irrefutable in that sense. But we need the shoe to drop. And part of that is happening with Medicare and Medicaid, because Medicaid, especially, which is the state-sponsored program that helps folks who are less privilege when it comes to income in the various states. So it's a state program. Listen, they're looking at you as a 25-year-old, 40-year-old, however old you are, at the fact that they've got to view how much you're going to cost them over a longer period of time, a much longer runway than, say, your insurance company that's tied to your employer, right? Which you're changing your job every 3, 4, 5 years. Medicaid works a lot different. You're going to be there. Most people are going to be lifers, right? And so they're starting to see it, which is why the Trump administration, I think, was so aggressive with saying, hey, listen, if you guys want access to our Medicaid markets and our Medicare markets, you've got to play ball on the price of these things and bring them down. And so they really saw, if we're going to open up a market of Medicare and Medicaid of 50, 60 million people, listen, you're going to lower the cost of these drugs. And so I think it's starting to happen just by virtue of, the drug companies agreed to offer across the board all the GLP-1s for $245 to the government. Now, prior to, they were paying for the diabetic versions of these $800, $900, $1,000. So literally they cut them, by 75%. The cost of these medications for the government. Now the government's going to be able to, starting in the summertime, offer Medicare patients these medications for $50, and many Medicaid folks, probably more like 2027, when those plans sort of restart, many states will add coverage for Medicaid as well. And those people will get it for free. And so a lot of the stuff that happens in the private sector, the private market, is sort of downstream of what happens with the government. And so I'm hopeful that over the next couple of years, we'll see the payers become a bigger part of this. But the drug companies, thankfully, aren't waiting for that. And they're going direct to consumer with these Lilly Direct, Novo Care, where you can get these now for, again, you can get the Wegovy pill, which is as effective as the Wegovy shot almost, for, I think it's $149 to start or something like that. So
Wow.
much more reasonable than, say, the $1,300 that injectable Wegovy cost when it first came out a couple of years ago.
Is there no way to force the insurance companies to think of this as a medical problem rather than an aesthetic problem?
I mean, is there a way to force them? I don't know the answer to that question. I mean, I think there's a Lilly and Novo thankfully saw this problem, right? Because ultimately the answer is kind of right. And the way that you do that is you, instead of running clinical trials for obesity, you run clinical trials for literally everything that's downstream of obesity. You run them for sleep apnea, you run them for heart failure, you run them for osteoarthritis, you name it. If it's associated with obesity, Eli Lilly and Novo Nordisk are running clinical trials for those. So then it becomes legally less defensible for them to not cover. In fact, tirzepatide Zepbound is the only drug, period, the only drug that is FDA approved for mild to moderate obstructive sleep apnea. So
Wow.
it's the only drug that's available. And so, ultimately there is legal liability. Now, unfortunately, what these insurance companies rely on is the fact that 90% of insurance denials are never fought by patients. So people don't understand that process, that when your insurance actually denies you the coverage for a medication, that's not the end of the story. And this is not a plug, but a former sponsor of my podcast, Claimable, exists to help people to fight those. And so a lot of the insurance denials are just algorithmically controlled with AI now. And so Claimable has found a way to help people fight back against that with, I think, 80% track record for non-obesity drugs. The obesity drugs still about 50%. But thankfully there's some companies that are kind of like fighting fire with fire and, leveraging AI to help fight back against these. But 90% of people that are denied never fight it. And most people win when they fight back.
So is it basically that there are two AIs? The insurance company has an AI, and then there's another company and the AI's job is just to deny everything, and then somebody figured out another AI just to battle that. That is wild, dude.
It's just a bunch of Claude bots running up the utility bill
Yeah.
back and forth.
Okay, let's see if we have any questions. Trace, does anyone have any questions for me or Dave?
We've got one from the Big Island boy.
Ah, Ryan.
Hey
How are you,
guys,
sir?
doing well, blessed as always. Question for both you gentlemen. Between Ethan's experiences and insight, and then Dave's GLP-1 expertise on the pen, inquiring minds want to know. Well, specifically me. I prepare to go on a GLP-1 next month, more specifically Victoza.
Okay.
And how crucial do you think integrating mental health strategies such as mindset shift or behavioral therapy is alongside the physical aspects for a true long-term weight management success? Do you gentlemen have any personal stories or tips?
I don't know. I've never heard of that drug. And I would just say I think that anything you do, you should focus on mindset and wrapping your head around, you know, because my thought too is like uh, the preponderance of my overeating had nothing to do with being physically hungry. It was a lot of the reason I overate was because I was anxious or sad or depressed or bored. And so I think that the most important thing for me has been to find ways to deal with that stuff outside of eating. Now, I imagine if you are taking something that's taking your mind off of eating and not allowing those things to be associated with it, and that's helpful, you're still gonna have those feelings. And Dave, please correct me if I'm wrong. I don't think any of these drugs address that stuff.
Yeah, I mean, other than people feeling, so sick that they just can't. But yeah, I mean, if so an interesting thing, and you say your name is Ryan.
Yes, sir.
Yeah, I appreciate the question, and I knew that Ethan would have a good answer for that. I'm still a fat guy, so I'm trying to untangle this all myself, right? But I think the fact that I'm still a fat guy is a pretty good indication that if you just focus on the drug is not a panacea for everyone. I think so. Two things. It's important to understand that hunger does come from three different areas, right? There's this hedonic hunger, right, which is that pleasure reward, like we're eating for enjoyment or fulfillment and some dopamine hit, right? And these drugs work on that to an extent. I would say tirzepatide the most in terms of what we've seen from the science, right? The older ones, not as much. But then there's this other hunger, which is called homeostatic hunger, which is more driven by your stomach. The absence of food causes your body to make hormones that say, hey, we're running low on food. If we run low on food, you're going to run low on energy. So we're going to produce a hormone called ghrelin, and we're going to make you hungrier. And then there's this microbiota driven hunger, which is driven from the gut. And that's where all these hormones come from: GLP-1, GIP, glucagon, all the drugs that they're kind of testing in clinical trials. So I would say, you have to deal with that hedonic hunger. The drugs aren't going to fix. You need to talk to somebody to help you with that.
Well, I appreciate the insight, Dave, and I have been following you since the onset of you coming on Ethan's podcast. And
thank you.
I have made some changes in terms of mental health. Started therapy last week. I vibed with the guys, so I really think that we'll be able to unpack, like Ethan said, the real root cause of the hunger, because it's anxiety, it's depression, it's failure to start, it's all the things. And so having this community, Ethan says the word every week, community is everything to me, especially out here in Hawaii. Just getting like-minded people together, even if it's over the internet, we can come together, talk our stories, share, bond. And the art of humility is such a powerful tool. So I commend both of you for what you're doing once again, and thanks for your time today.
Thank you, Ryan. Good to see you, brother. Trace, anyone else?
We have a question from Katie.
Hi, Katie.
Let me bring her in here.
Hello.
Hi.
You guys can hear me?
Yes, ma'am.
Okay. I just kind of wanted to ask this question. I've been on semaglutide through a company called IVIM for since like November, a little bit before Thanksgiving. And I'm on, I don't know, I'm on like what they consider, I guess, the highest dose right now that I can be on. And I do not notice a difference at all. Like, to be perfectly honest, like I haven't lost any weight on it. I lost maybe a few pounds the first couple of weeks, but it's been pretty much the same. And I'm just curious if that's like, I don't notice a difference in my hunger level or anything, really.
I don't know how to answer this question, Dave. This is for you.
I love this question. First of all, I think it's important for you to know, Katie, that patients don't fail treatments. Treatments fail patients. We talk about where this hunger, what's driving this hunger, what hormones you might be dysregulated in. We're at the advent of what hormones these drugs will actually work on, and it's just not a panacea for everyone. Again, the more powerful tirzepatide that we talked about has never turned my hunger off. But then I meet people every day who are like, I can't even look at food, right? And so the first thing to know is they don't act the same on everybody, and people don't fail treatments. Treatments fail people. And so what I would really encourage you to do, Katie, is to talk to them about tirzepatide. Tirzepatide hits a second hormone that really helps with the mental side of things. When we talk about food noise and sort of that sort of nagging thought about what am I going to eat? Where am I going to eat? When am I going to eat? It just has a way of turning that off for people. And so the good news is that you started on semaglutide. It wasn't for you, but that's not the end of the runway. You still have this new generation of tirzepatide that you could try. And then if that's not the one for you, there's ones that'll be coming out even later this year that may end up hitting what you're hoping to get.
Yeah, the Eli Lilly, I actually bought stock in Eli Lilly just because of this drug that's coming out that people are talking about. I think it's called GGG, right?
Yeah, retatrutide, which is the triple. So it's GLP and GIP, just like tirzepatide, and it adds a glucagon component, which is why they call it the triple G: glucagon, GLP, GIP. And that glucagon, so every drug before it for obesity worked centrally meaning you eat less, right? Retatrutide, which will be coming out in the early part of next year, actually is the first drug that will help you to expend energy as well. So you're hitting it from two different standpoints.
That's an exciting drug. I mean, after our whole conversation today, Dave, I don't know if they just get busted by the compounders or what, and it doesn't, none of it matters anyways, but like
Maybe.
that sounds awesome. And from what I read, it's on par with bariatric surgery, right?
Yeah, that one is about in there. I think it was the first phase 3 trial we got data for this year. I think it was around 30% over 72 weeks. And the other thing, Novo Nordisk has another one coming out later this year. It's semaglutide plus something called cagrilintide. So CagriSema is the name of that one. It's actually coming out later this year, early next year. And that uses amylin, which is another hormone. So lots of things coming down the pike. So let not your heart be troubled, Katie.
Yeah, and Katie, the only thing I would add to this is these are drugs are not how I lost weight, but I will say that every time I lost weight through a single intervention, I gained the weight back, or I struggled, or I didn't lose weight. And I think that these things are really can be very powerful tools, but I do not think they're the be all end all. I think it still requires more work. Which sucks to say, but that's my belief at least.
Yeah. And unfortunately for some people, it requires more work than others. So if you jump online and start hearing those stories, it's way easy to fall into that trap of what's wrong with me. This person's on the lowest dose and they lost 100 pounds. And here I am at the highest dose and I'm still hungry and eating my arm. Again, patients don't fail treatments. Treatments fail patients, and there's more to come.
Yeah. We got any more, Trace?
We do indeed. We have one from Ted.
Hi, Ted. How are you?
Ted's on Mars.
That's awesome.
Hey, can you guys hear me now? Sorry about that.
Yes, all good.
Great to be here. Dave, since we're talking about GLPs, I'll just throw this out there. I'm a longtime Trulicity user, been several years. Last year, my wife got cancer. And prior to that, the food noise was muted. That pulled out all my stress. And coming out of that fog now, things are getting better. I'm thinking of talking to my doctor about tirzepatide. I really don't think I've lost much weight. Maybe some muscle loss from not eating, which is obviously the biggest thing we want to avoid.
Right.
But it seems like from what I'm hearing, tirzepatide may be the way to go.
Yeah.
For the blood glucose matter as well as the weight loss.
Yeah. So you're type 2 diabetic, Ted?
Yes.
So Trulicity was the first once weekly GLP-1. It's an older drug. But honestly, what Lilly did was they just built off of that technology of Trulicity, added another hormone called GIP. So you're getting straight GLP-1 right now, which is pretty good at shutting off hunger. GLP is, it kind of acts as a blunt object. You feel full. GIP is actually that one that's more, I believe, active in the brain in terms of when you talk about food noise. So the stress, like it sounds like a lot of your eating was probably driven by stress as a coping mechanism. Like your wife has cancer. I can't imagine. So first of all, my heart goes out to you, Ted, and to your wife. I hope that she's doing well.
Those are good.
That's great. I'm glad to hear that. Yeah. So I would definitely talk about GIP because, or about Mounjaro, because at the end of the day, when you look at the studies for Trulicity and Mounjaro, it's better at controlling your blood sugar. It's better at weight management if that's what you're into. It's just the next generation of drugs, and because you're diabetic, you'll probably have pretty good coverage for it and pay very little monthly for it.
Cool. Thank you.
Yeah. Thank you for the question, Ted. And I'm also sorry to hear about your wife. My own anecdotal experience has been I could be on a diet that while I was home and my schedule was normal and everything was great, I'd be trucking along fine. And the minute I'd go away to work, I would adhere to the diet perfectly, and yet my stress would rise and I would find myself gaining weight. Stress can be a real bitch. Trace, who's up?
We've got Wes coming at us now. Let's drag him in here. Everybody's ready.
Hi, Wes.
Hey guys, thanks for having me on. What kind of inspired me to chime in is what you said about it being a tool. And so my question is kind of about, I see the GLP-1s get moralized a lot, like especially on all of the weight loss communities that you see on social media. you see a class of people that are like, oh, I did it naturally. And then they'll talk about not having surgery, or they'll talk about not using GLP-1s. And I think that's fine and that's great. I don't agree that it's a thing to be celebrated, because I think that people, if they understood GLP-1s as a tool, the same way that they see steps as a tool, the same way that they see gym or a trainer as a tool, it could really reset the wide way that people think about these particular drugs, right? Because I think that now we have enough information that we're not looking at like the fin thing, right, from the 90s or whatever. There's not these super dangerous underlying things that we're going to run into. Like, they've been used for a decade. We know they're relatively safe. And I just, if you know, I'm curious what you guys think, because for example, in the bodybuilding world, like Dr. Mike, like these guys talk about GLP-1s and they talk about it as a tool. They talk about it about one thing in their bag that they can use or not use depending on what they're doing. But I feel like when I'm over in weight loss, it's all the way in, all the way out. And that creates this impression that the drug is just doing all of the work for you. And like, how could the community start to reset that? Or how could the people at the top start to reset that conversation to make it a little closer to what it is in reality?
I just want to say, I don't know one person who did one thing, and that could be a GLP-1, who just hopped on Ozempic and then got to exactly where they wanted to go and went, that's all I did. And look at how great my life is. I don't know one. I don't know one person that did keto and that happened. And I think there's a lot of there's the naturalistic fallacy, which is just, people, if you eat processed food, you're not doing it right. Or if you do this, listen, I didn't think of MyFitnessPal as cheating, but it saved me a lot of time and energy and stress on doing all the calorie crunching that I wound up having to do, that I did for a few weeks before I discovered it. And I was spending hours a day writing out figures, everything. I think you should have a very, very deep, full bag of tools. The gym is not a tool. Your access to food that you need is part of your arsenal. I think all of this stuff is a tool, and I think these are the best. Like we talked about fen. I was put on fen in the 90s. I didn't sleep for a week, and my parents were like, "This is crazy. Get him off of this." Thank God. And I didn't have any bad effects, but I would have done anything possible if it was going to help me. But I was really focused for a long time on single solutions. If it was just don't eat carbs, that's what I'll do. And I'll go head down and I won't eat carbs. And I think a lot of people are looking at these GLP-1 agonists as a single solution. My personal belief is that they're going to be a tool, and there's going to be other effort that's going to be need to put in to get to where you want to get to. Um, but like, if we're just talking about health, there's a ton of data and literature on a 5% decrease in weight can be a massive boon to health. So if that's all you want, then maybe that's the be all end all. I just don't know a lot of overweight people that go like, I want a boost to my health and that's it, you know? So I agree. I don't think they should be moralized at all. Dave,
I'll just add to that. I would reframe the whole kind of conversation around less around GLP-1s and more around the disease of obesity. And I think that the more people can understand the hormonal dysregulation that happens and why these medications end up working for people, typically is because there's severe dysregulation going on in there, and there's a whole host of reasons why, but there's obviously a spectrum. And I think that's the thing that people don't understand about the disease of obesity, is not everybody that has obesity experiences it the same way, right? In terms of where the overweight is coming from. Maybe it's coming from fatty liver. Maybe it's coming from a pancreas that's not functioning properly, or, there's any number of reasons. We don't need to hash them all out. But I think if people understand that it's a disease with a spectrum that's going to require different levels of treatment, just the same way that controlling lipids are different for different people, and the fact that there's a genetic component too. So we see that in the GLP-1 community all the time. Even, people like moralizing the dose that they're on, right? Like, well, I lost all my weight on 2.5. Well, good for you. Like, you don't get an award for that. Like, at the end of the day, the 2.5 worked for you, it treated your disease, and that's great. But for somebody who maybe needed the full 15 dose, or somebody like Katie earlier who had to get all the way up and now she still needs another treatment, like, again, I go back to the fact that there's no morality here. There's just a spectrum of disease that needs to be treated.
And I think to that end, the other thing I would say, you said about controlling lipids. People talk about, oh, let me get on these drugs, and then it's a race to get off. And I would love to see that reset as well, right? Because if you have to control your lipids, you're not like, oh, when can I get off of this, right? Or if you have high blood pressure, that's, there are ways you can naturally bring it down. But if you have to take blood pressure medication forever, that's a medical reality for you, right?
Right.
You're not like, oh, I'm failing.
I have a kid with type 1 diabetes. There is no race to get her off of insulin.
Right.
And her blood sugar is corrected every day. And every time it's corrected, we don't go, well, we'll solve that,
Right. Insulin doesn't get to the underlying issue of a pancreas that's malfunctioning the same way that GLPs don't get to the underlying issue of what's causing the hormonal dysregulation. They mask it, right? And until we can get to the science, and the science is getting there as to how we get to those underlying root cause issues of hormonal dysregulation, we're going to need the medication, and there's no prize for using less or none to get to where you want to be.
Yeah.
Thanks, guys. Appreciate it.
Thank you so much. Okay. Before we go, I want to just do a quick lightning round of questions with you, Dave. Okay.
Yeah, let's do it.
Favorite workout?
Oh, my favorite workout for me is anything that I'm doing with my kids. I love to play sports with my kids. So that doesn't feel like a workout to me. That's why I love it.
Love it. Least favorite workout?
I would say the inverse of that, something where there's somebody breathing down my neck to do one thing or another, and it feels like punishment.
Perfect. Go to hype music.
Hype music. I find myself going back to Metallica an awful lot.
Nice.
I like Metallica. It gets me amped up.
Post-workout snack?
Yeah, I love natural forms of protein. So I'm going to be getting it in with eggs, steak. I love to get my protein in the form of meat.
Beautiful. And what is a workout you never skip? I'm guessing what you're going to say, but I want to hear you say it.
A workout that I never skip. Well, I mean, I would have to say any opportunity that I get to move with my kids, I never say no.
There you go. Best advice you've ever received on your journey?
Don't compare it to others.
Awesome. Biggest motivator?
Being around for my wife and kids.
Beautiful. Okay. Now, if you could have any meal, shame, calories don't matter, they're not counted, what would it be?
Oh my goodness. That is a great question. I think probably would have to just go back to, I'm very boring. It's the same thing that I eat after a workout. I love a good steak, but I'd have it with a nice baked potato.
Beautiful. I love it. Dave, thank you so much for joining us. I think you're awesome. I think what you're doing is awesome. And please remind the people where they can find you on social media besides onthepen.com.
Yeah, on social media, I mean, our handles kind of differ. I was man on the Mounjaro forever. Now it's like, if you just go to otplinks.com, that's sort of the gateway. It's all of our links. So OTP for on the pen links, otplinks.com, and all of my social handles are there. And we put a little bit of something different everywhere. So it's worth following us in all the places.
I agree. You're a great follow. All right. Today's Daily Nudge comes from Bad Bunny, who said last night at the Super Bowl, "My name is Benito Antonio Martinez Ocasio, and if I'm here today at Super Bowl 60, it's because I never, ever stopped believing in myself. You should also believe in yourself. You're worth more than you think. Trust me." 10 years ago, he was working at a supermarket. Last night, he was on the Super Bowl. He was the halftime show. It's the biggest music show in the world. And that's what happens when you don't quit. Before we go, a couple quick reminders. If you're on Zoom, stick around for the community update session immediately after the show. We'll chat it up, and there might even be a movie review from one of the producers. And again, send your questions to Ethan Suplee Show at twoway.tv, and head over to our subreddit r/Ethan Suplee LifeLOng. The link's on the screen and also in the YouTube notes with all of our social media goodies. We'll see you back here in 2 weeks after a short break for President's Day next Monday. And until then, remember, health is lifelong, built, not born.